Hi guys, it's Professor Costa, and today we're going to be going over patients with impaired protection, caring for patients after tissue and organ transplantation. So, what organs can tissue can be donated? And this isn't even a fully inclusive list. The ones you're probably the most aware of are kidney, liver, lung, heart. But we can also have donated valves, bone, tendons, skin, pancreas, intestine. The corneas, and don't forget blood and bone marrow. And again, this isn't a fully inclusive list. There are other things that I'm sure I missed, but the big ones, the biggest one that most of you should definitely be familiar with is kidney transplant. So the exemplar, what we're going to talk about today, kidney, liver, heart, and bone marrow. Those are the ones that are most likely to show up on your NCLEX or HESIs. So one donor can save 8 lives, which is, when you think about it, amazing. The heart, there's 2 lungs, liver, pancreas, 2 kidneys, and intestines. And that's the minimum. So sometimes they'll even use part of the liver on one if they have multiple people that are a match. Because the liver can be divided and is one of the few things that grows back. So you can actually transplant from a living donor part of the liver, or if you have someone who's they're being harvested their organ, then they may actually divide that up. Okay. So methods of transplantation. So they have autografting, and that's within an individual. So that the most common thing that you see autograft would be skin, and that's because of burns. Or they may also do vessel transplantation. So someone that has needs coronary artery bypass grafting. Grafting is the operative word there. A cabbage. So they will take a vessel from another part of the person's body that they don't need to stay alive, and they will connect that and try and open up the coronary arteries. Okay, so cabbage is a form of autografting. Okay, then we have allografting with it, which is within the same species, which is hard to think of, but yes. So allografting is between people of the same species, and xenografting is from different species. So, for instance, the pig valves that are sometimes used for patients who need valve surgery often come from pigs, and so that would be an instance of xenografting. Okay. So types of tissue donation. So we have living donor, which is related or unrelated, and donations are from a person expected to live normally after the donation. The most common ones that you hear are people that are healthy and have 2, beautifully working kidneys, and they donate a kidney to a relative or on behalf of a relative. Maybe we set up a multiple donor situation and everybody kind of trades kidneys. The thing about this is that person is expected to live normally after the donation. We have a deceased donor, also called cadaver. I can never say this word. I'll just say deceased donors. This includes donations after brainstem death. I have taken care of donors in a critical care environment that were deemed brain dead. All of the testing were done, the EEG, everything, and yet they were young and their other organs were healthy. It's usually following a severe head injury. We see that a lot. And, these donors have to be in, not perfect health, but you don't want a sick organ, right? The person that you're transplanting it to is already compromised as it is. And so, especially for lung donation, you need a very pristine lung. Like, they want perfect lungs, because the lungs are wimpy, as you well know, and this whole process makes them prone to inflammation. So if the lungs have anything going on with them, then they won't take them. So we'll also use from a deceased donor. And then UNOS, this is the United Network for Organ Sharing, and they use a scoring system to determine which patient is offered a specific organ. And there is a list. Okay, so more about UNOS, right? So prioritizing patients for transplantation. First things first, to be on the waiting list, you have to be listed with your blood type, height, weight, and they automatically screen you for potential matches, right? Geography does play a part because not every organ survives very long once it has been taken out of the donor. So hearts and lungs have less time to be transplanted. So you can't like fly a lung from Alaska to Florida. It's just, we want to optimize having this patient survive and having the organ survive. So geography does play a factor. So we use a radius from the donor hospital instead of regions when allocating those organs, right? And then the right-sized organ, right? So you can't stick a heart from someone who's 7 feet tall into someone who's 4 feet tall. Proper organ size is critical to a successful transplant, right? So children often respond better to child-sized organs, which nobody wants to think about. That's a horrible thought. But pediatric candidates have their own scoring system, right? Children essentially are first in line for other children's organs, okay? It is horrible to think about that, and that's something that these families have to contend with, is realizing that they're hoping for something to save their loved one, and at the same time dealing with the guilt involved about the other family's loss. So here are the factors in organ allocation. So blood type and medical factors weigh in, right? So, but each type of organ has its own distribution policy. All right. So kidney, part of what goes on, because kidneys are the thing, the number one thing. If we could manufacture, or grow these, and someday we will grow these in a lab, this would be the hot commodity. And the reason's pretty simple. The kidneys are the martyrs of the body. They're the first thing that gets shunted if the body is in distress, which is why we see a decrease in urine output with shock, right? They're the first place that our body takes away perfusion to is the kidney. And so, and we also have patients with really bad hypertension that's uncontrolled, or diabetes was one of, hypertension and diabetes, two big risk factors for developing end-stage renal disease. But we can keep these people alive for a lot longer, which is the other part, which is why there's so many more people in need of kidney transplants. One, the risk of developing end-stage renal disease is higher because the kidneys will go first. But we can also keep these people waiting around longer, and therefore there's more people waiting because we have dialysis, which we don't have. We can't do that with the heart and the lung. We can take you to dialysis a couple times a week and filter your blood and keep you around. Some of these people are on the list for years. So waiting time is a factor when they look at who's on the list and who gets moved where. All right. Obviously, HLA, the immune system compatibility, is a factor. If they were a prior living donor, meaning you stepped up maybe when you were 22 and you were a living donor and donated a kidney, and now something has occurred in your life where you're now in need of a kidney. All right, so that actually plays a role here. Distance from the donor hospital, so how far away you are, your survival benefit. How likely are you to survive when you receive this kidney? Or are you going to stick around? Do you have a good possibility? Or do you have like all these other comorbidities and your outcome isn't even for sure, even if you get the kidney? Then you may not get this one. And obviously pediatric status trumps. So kids would be moved way up on the list to get a kid's kidney. Lungs, survival benefit, right? So people who have severe lung disease, how likely are they? Remember, these lungs are wimpy, even in a healthy individual, as we've seen with coronavirus this summer. So making sure that the person would be able to live past the surgery. This is a big, big surgery, all right? Huge surgical procedure. They got to literally crack you open and take out your old lungs and put in your new one. And usually it's one side. You usually get one lung. Though I know someone who had to, who was up for a new lung, and then the night that she went in for her transplant, there was no other match for the other lung, so she got both. All right. And even then, with 2 new lungs, she had not a great outcome because this is a huge surgery, and she was a little older. Medical urgency. How close are you to dying from this? Definitely moves you up on the list. How long you've been waiting, the distance from the donor hospital, and again, pediatric status. Liver. So I don't know how many of you have dealt with acute liver failure. It's very different than our chronic cirrhosis patients. And I'm not saying that that's not a bad thing, but acute liver failure is a very different animal than the chronic one. Acute liver failure, I've told my husband this, taking care of these patients over and over again, I would rather die of just about anything else than liver failure. It is horrific. You swell up like 3 times your normal size with fluid because your body isn't able to make proteins. You're not able to make clotting factors. You're not able to break down, the bilirubin. It's horrible. And on an acute scale, these patients don't last very long. So that's what I mean by acute, the medical urgency. Like if you're in the ICU days from death, then obviously you would be higher up on the list depending on the situation, than someone that has chronic disease and is relatively stable otherwise, right? Distance from the donor hospital and pediatric status are also issues. All right, heart, again, medical urgency. Are you on, an LVAD? Are you, days from death? That would play a role. Okay, so obviously the sicker patients who are a match and live close to the hospital are going to be the ones that get matched first. There are families that actually move closer to where their donor hospital would be to improve the odds that they would get the transplant. It's scary, but that's things that these families have to contend with. So we're going to look at the human leukocyte antigens, the HLAs, and this is what patients have to be a match with the donor, right? So we know that our body only protects itself, and that includes things like, that's why we worry about people with knee replacements or hip replacement or an internal shunt or anything, pacemaker, anything that gets implanted in your body that you weren't born with doesn't have the HLA on it, doesn't have a little flag, t-shirt or whatever that says, ooh, I'm part of the team. And so your body won't protect it. And in many cases, your body will attack if it's got proteins on it. So that's why our body will attack, a donated kidney because it has proteins. Whereas if we put a piece of metal in your body's like, usually just leaves it alone because there's no proteins on that metal. It's just there. So anything has a risk of rejection that is, coming from another living thing. And the reason is because of these HLAs. Your body doesn't recognize it as self and may attack. So they're found on the surface of most body cells, right? And they determine the tissue type of the person. It's very unique. The book's calling it a universal product code. I like to think of it like a team t-shirt from a basketball team, but whatever, way, just our body has a way of recognizing its own cells. And it is the key for recognition and self-tolerance. So self versus non-self, right? So The body recognizes its own cells and doesn't attack, and it does not recognize a non-self cell and will attack it. Okay, this is kind of along the lines of there's some miscommunication when we have patients with autoimmune disorders. There's an issue where the body is not recognizing cells within the person as self, so they're not recognizing members of their own team and they attack. And that's what's going on with most autoimmune disorders. Okay. All right, so let's talk about matching. So potential donor is HLA typed, right? So we're looking at a kidney right here because that is the most common one. And it's sent to a hospital where a good HLA match is registered, right? So they need to have the kidney and a blood sample from the donor go to the facility. And the reason why is they want to cross match the donor's blood with the recipient's blood. And and they'll do this outside of the body. And they want to make sure that there's no immune reaction. So in the cross match, donor B cells are mixed with the recipient's serum. And in this case, the one on the left, you'll see that the antibodies bind to the donor cells. That means a transplant can't take place. On the right, you'll see that the recipient's blood doesn't attack the donor's blood, and therefore the transplant can go ahead. This is kind of similar to, I know you guys don't do a lot of blood transfusions yet, but whenever we have patients that are receiving non-emergent blood transfusions, we have a patient that gets needs a unit of blood. We draw a vial of blood from them. We bring it down to the blood bank. The blood bank takes a little bit of their blood and a little bit of the donor's blood and puts them together, right? And that's the cross match. And they want to make sure that there's no reaction outside of the body before they try it inside of the body, which really does make sense, right? And so there you go. All right, so preserving organs. This tells you why the location makes a big difference in some of these, right? So donated organs require special methods of preservation to keep them viable. And they really do use those like igloo coolers that you want to throw a 6-pack in, right? You've probably seen these people walking in and out with the igloos, and you probably haven't even like put it together exactly what it is. So we want to keep the cells alive between procurement and transplantation. So common maximum organ preservation times include a kidney, 24 to 36 hours, pancreas, 12 to 18, a liver, 8 to 12, and a heart or lung, 4 to 6. So that 4 to 6 you can definitely see, and that's pushing it out too. So that's why it's better if geographically the donor and the recipient are close to one another. This is that paired donation. So let's say we have, your brother, for instance, and he needs a kidney transplant, and you are a healthy individual with no kidney disease, and you wanted to donate to your brother, but you weren't a good HLA match. Well, what they would do is they try to set up a paired donation. So maybe there's somebody else in the same situation with another family member, and you're compatible with that other person's family member and vice versa. So we can set this all up at the hospital ahead of time. Both, families come in and they literally do the transplantation the same day, they don't have to do it the same day, but in many large metropolitan areas, they can do it on the same day for good faith measures. So waiting list statistics. So here's the sad part. Nearly 2 out of every 3 people on the waiting list are over the age of 50. Almost 2,000 children under 18 are on the waiting list, and almost 70,000 people on the list are ethnic minorities. Okay, so waiting list by ethnicity. This was a few years old, but this list doesn't change very much. Caucasians were about 41%, African Americans 29.2%, Hispanic 19.5%, Asian 7.7%, and everyone else gets grouped in together with the smallest group. which is sad when you think about it. And why are there more African Americans? If you think about it, they're more likely to have hypertension, and there's a lot higher incidence of kidney end-stage renal disease in that population. Now the numbers are right, but the graph looks a little off to me because 82% would be a much bigger piece of that pie. So ignore the pie, all right? I stole this right from UNOS, but their graph is definitely off. So the kidney is the big, right? Like I said, that's the big hot commodity. The majority of people waiting for organs are waiting for a new kidney. And again, the reasons for is one, it's more likely to occur. And two, we can keep those people around for much, much longer. Okay, liver disease and heart, lung, and other. Why are less people waiting for lung and heart transplants? Well, because they're the central way we stay alive, and we're unable to keep those critically ill patients alive long enough. And also, we're not going to take a heart out of someone. There's no such thing as living heart donors, right? It's usually taken from a cadaver donor. Here's transplants performed in 2016 by organ. So you'll see 19,000 kidney transplants, 7,800 liver. You can read the rest. Sorry. So kidney transplants they're not routine, but they're done in many facilities. And that's why you're more likely to see a question on that on your board or HESI exams. So eligibility for organ transplantation. Obviously, you have to be an end-stage organ failure. You can't just decide, oh, I feel like having a new kidney. It has to be failing after it. You have to demonstrate that you need the organ. Now, this is controversial, but age less than 70, and that, again, this number may go down depending on comorbidities. So if you have a lot of other diseases, they may make this age even younger. No contraindications, which we'll see on the next slide. And here's a really important one. You have to have the ability to follow the treatment regimen. So I had this really nice guy, inpatient. This was when Memorial Hospital was still open. And he was only 26, and he used, some substances, and he injected, and he had caused a really, really severe valve disease, and he needed new valves. But he knew that most of the time he was homeless, and a lot of times he was using substances. He was not a good candidate at that time, right? So if you have untreated or undertreated psych disorders, if you have issues where you wouldn't be able to follow the treatment regimen, and they're strict, right? We literally gave you the organ and not to someone else who needed it. You have to show that you're going to be a good owner of this new organ and be able to follow instructions. And so, for instance, like with a lung transplant, if it was a smoking related disease, you have to demonstrate for sure that you gave up smoking and that you're never going to do it again. If this was an alcohol related transplant for a liver, you have to demonstrate that you are clean and sober and no touchy. You're never going to touch alcohol again. Those have to be demonstrated. So contraindications to organ transplantation would be an active malignancy. So if you have cancer, unfortunately, the cancer could invade the new organ and makes it useless, and two, the medications that we give you would decrease your likelihood of beating this cancer, right? So if you have advanced lung disease, and this is for a non-lung transplant patient. So let's say you're looking for a new kidney, and you also have advanced lung disease with chronic O2 needs, you're not going to get the new organ. Ongoing infection, so overwhelming, massive untreated HIV/AIDS. So I have seen clients though who are HIV positive get transplants, but it was a patient who was following their regimen, was actively, very low viral load, things like that. All right. But if you come in and you have advanced acquired immune deficiency syndrome, chances are you're not going to get the organ. All right. So life expectancy less than 2 years for reasons beyond the specific organ failure. Again, so you're coming in for a new kidney, but you have severe other disease, and the likelihood of you living even with the new kidney is low. They're going to save that organ for someone with more life expectancy. Active substance use, nope. Okay. Ischemic cardiac disease in a non-heart transplant patient, I already said this, right? So not amenable to revascularization, meaning so they're doing your workup for your other organ transplant, and they find that you have some, coronary arteries that aren't in the best shape. They may just see how you do with a stent or a cabbage, and if they're able to fix that other issue and you're stable with that, then they would come put you back on the list and put you back on the transplant list. Severe peripheral vascular disease. So you need to have relatively good peripheral perfusion. Why? Because we're transplanting an organ that needs to be perfused into your body. If you don't have the ability to perfuse that, they're not going to waste the organ. Poorly controlled psychiatric illness, right? And I alluded to that already. Minimal rehabilitative potential. So this doesn't always make itself evident before the transplant, but here's the example. The person I'm talking about that received the double lung transplant never made it out of the rehab facility and was there for months. And so because you have to be able to follow the regimen and work with your PT and OT and all the things that go along with major surgery and now a new organ, if they see a red flag beforehand that you were, I don't want to use, I'll use the word non-compliant with something else, or, you got a new knee and were never able to walk again and are in a wheelchair, you have to have at least some rehabilitative potential here. Poorly controlled diabetes, right? So your diabetes has to be under control before they go and do this, because we're going to upset that sugar already with the transplant, and because of the inflammatory response and the medications, and now you're going to add poorly controlled diabetes, we're going to kill that new organ. And morbid obesity, so BMI greater than 40. So there are clients that undergo other like weight loss surgery options in hopes of getting an organ for something else. So definitely don't want to add morbid obesity to this list. So they would be advised to lose weight and get to a lower BMI before organ transplantation would be considered.